Okay, so we go to the second case. Today we have two cases, so we will have good time to discuss. And yes, Dr. Zainab. Dr. Zainab is the resident of neurosurgery here. She will be presenting the second case. Zainab?
Yes, sir, I'm here. Should I start?
G, please, please.
Right. So the second case is a 40-year-old gentleman who presented to us with history of headache and confusion for 10 days. At the time of presentation, his KPS was 10. So we requested for an MRI brain, which
No,
showed.
KPS was 90. Zainab, KPS was 90.
Yes, sir. Yes, sir, 90.
Okay.
So we got an MRI brain which showed two contrast enhancing intraaxial lesions. One was frontal and the other was parietal. So considering multiple lesions, we requested for a CT chest, abdomen and pelvis with contrast, and it was normal and did not find out any other lesion. Next, please.
We can, Dr. Shumaila.
Yes, these are T2 weighted axial images, and here I can appreciate that there are at least two focal abnormal signal intensity areas which are heterogeneously hyperintense on T2, and both of these areas are showing significant vasogenic edema. One of them is the left frontal, and the second is in the left parieto-temporal region. So there are few T1 weighted hyperintensities in the parieto-temporal region, and both of the lesions are causing significant mass effect, effacement of ipsilateral lateral ventricle. There is sulcal fine herniation, and there is possibly some descending tentorial herniation as well. So there is some hemorrhagic component seen as T1 hyperintense signals, and then on post-contrast images, there is significant post-contrast enhancement. It is nodular, thick traces. It is showing internal areas of necrosis, which are seen as non-enhancing centers. And do we have any more images?
Yep.
And these are FLAIR coronal images, and this vasogenic extensive edema is more clearly seen on FLAIR images. Possibly there is some extension of edema across the midline through the corpus callosum to me, and I will consider primary multifocal high-grade neoplastic lesion as first differential, and then definitely second differential will be metastatic deposits, but they're like the way they are, because I have seen a few cases with multifocal GBM. Mostly they are in the same cerebral hemispheres, and the enhancement pattern, the edema, and rest of the imaging findings are more in favor of a primary neoplastic brain lesion, which is multifocal.
Okay. So, Dr. Shayan, do you please your input?
Yes, I agree with Dr. Shamaila in totality. Yes, it is. It looks more like primary intraaxial neoplastic lesions rather than metastases. But of course, we always have to give a differential.
Right. So,
I have Hassan.
yes, sir.
I haven't seen a patient with such type of the picture that looks like a glioma, but two glioma,
Yeah.
highly malignant gliomas in a one patient. This is the first case I have seen enjoying this big CT scan.
Yes,
And
sir.
also Dr. Shan is saying that this is a very rare entity.
Yeah. Yes, sir. So Dr. Shayan and Dr. Shumaila, we'll call it multifocal, right? We can call it because my understanding if there are two contrast enhancing lesions, but on the flare, if we look at the flare signal, connecting these two enhancing lesions, we call it multifocal. But if it is like the contrast are there and the flare are not making the connection, then we can call them multicentric. So in radiology also, do you use those terms, or how do you Sorry if I'm just asking for my own. So yes, Dr. Riaz, it is a little bit, it's not very common.
All right. So multifocal, I believe, to my understanding, is pertaining to one lobe only. But if it is involving more than two lobes, it can be multicentric.
Okay.
Am I correct?
I
Yeah,
think it is not mentioned in literature as such. These are interchangeable terms, and most people use them in both the ways. So I don't think that using this terminology will make much difference. They
Mostly
are
we
presenting at one point in time, and they are in one cerebral hemisphere. Maybe there is some subcellular infiltration which is not visible, and they are connected as well. But the way they are presenting, because I have seen at least 5 to 6 patients who have presented with this, and initially in few of them it was there were smaller lesions and larger lesions, so it was considered as multifocal, like it is tuberculosis, but later on it was found histopathologically. So being working in CyberKnife, I'm able to see a lot of histopathologically proven lesions and their initial presentation and later presentation. So I have seen at least 5 to 6 cases with such presentation. I think we should focus on the primary MR characteristics of the lesion and then make a decision according to that.
Right. So here, I would like to add something like since it is involving the frontal as well as the parietal lobe, but though it is ipsilateral, but we see some intercommunicating vasogenic edema. So high-grade gliomas tend to infiltrate the adjacent parenchyma beyond their enhancing margins. And we also see that there is some involvement of the corpus callosum as well. So it is crossing the midline. So we see it's like behaving like a gliomatosis cerebri involving at least 2 consecutive lobes. So it appears to be very aggressive. It can be a single tumor only, showing multicentric enhancement in 2 different lobes, maybe intercommunicating at a micro level.
Right.
Is it possible that if
do you think as it is a relevant question, do you think that
Sorry, Dr. Shumaila, आपकी
glioblastoma-
आवाज थोड़ी सी, yes, please.
do you think that gliomatosis cerebri will show this kind of enhancement? Because mostly there is not much enhancement, although there is diffuse involvement edema and everything, but the enhancement pattern is very typical of a high-grade glioma. Like gliomatosis does not enhance like this.
Right.
Well, gliomatosis is not a histological type, is just a radiological term just to emphasize that more than one lobe has been involved by the tumor. So it's like a term just to describe how the tumor is behaving.
Dr. Riaz, you were saying
yes,
something?
when we are talking about the little bit confusion in the diagnosis, so is it a normal routine of the radiologist that he can go to the spectroscopy?
Okay, that's a very good question. Dr. Shumaila, spectroscopy will be helpful.
As a radiologist, in my opinion and in my experience, I don't give so much weightage to spectroscopy in most of the cases. I rely basically on the baseline images and the behavior of the lesion or the baseline sequences. I mostly report spectroscopy, which is advised by a surgeon. Like it's mostly the demand of neurosurgeons. But my personal experience is that it very rarely adds something to your, original opinion. I haven't seen my opinion changing over years with the help of spectroscopy. It is very rarely, diffusion helps a lot. Susceptibility weighted images helps a lot, but to me, spectroscopy does not help in most of the cases. Like it does not change your opinion.
Okay. Dr. Shayan?
Yes, I agree, because MR spectroscopy may help you when you are differentiating a neoplastic lesion from a non-neoplastic lesion, rather than when you are sure that this is a neoplastic lesion, then I think we don't need a spectroscopy to confirm that. We only need histopathology to know the type of tumor.
Right, to have the tissue diagnosis. True. Okay, so here, yes, Zainab, we did the left parietal. Yeah.
Yes, so considering multiple lesions, but there were no other lesions on the CT chest abdomen and pelvis, we planned the patient for surgery and he underwent neuronavigation guided left parietal mini craniotomy with debulking of the lesion.
So
And
I do
why did you choose left frontal rather than left frontal?
that was my question, and that I think that we can have a good discussion. So I chose sorry. So just a disclaimer. This was my patient. So I chose the left parietal because it was more convenient, more easy with a small craniotomy, less morbidity, less invasive surgery to get the tissue diagnosis. Because getting the whole, the contrast enhancing frontal and the parietal and thing, and on the dominant hemisphere, right-handed gentleman, we will end up, giving a lot of deficits. So that was my reasoning to go to the left parietal. What you would have done, Dr. Altaf?
Well, I think we discussed pre-operatively, but having said that, just to become a devil's advocate, why not left frontal? Because there is a lesser brain parenchymal
Yeah.
traversing point, and
Yeah.
the tumor is well kind of well, even parietal is also kind of well defined, but the frontal is more defined than the parietal
Mm.
and less infiltrating, and it could have been completely resected rather than the parietal.
Okay. And you will go only for the one lesion, or you will go because there is a possibility of going for both lesions.
That is also a valid point because going for both lesion means debulking and
Yeah.
giving a kind of more chance to relax the brain, and then get the radiation and CCRT after 4 to 6 weeks, because just biopsying it won't relieve the pressure.
Yeah. No, so we did the debulking. The patient is doing well. We followed him up, and yeah, but I agree. Like, going, because there are some reports that I have seen also where we can go for the both and using even different insulin. Dr. Riaz, what do you think? Okay, fine. I'll come to you after having Dr. Riaz's opinion. This is
I would like to go from the frontal because again, say I said, because of parietal, the middle meningeal vessels are very difficult to control, and I think the preferred site is the only and only left this frontal, and I would not enter with the parietal because this is a dominant flow, and danger is more going into the left posterior parietal region.
Mhm. Okay.
So how was your patient post-op?
No, he's doing good. He's great. So I use the navigation. So I wanted to keep, the normal parenchymal. So the thing is, like, just giving you my opinion again, like, I think it's a very interesting case. That's why I kept it for the discussion, and I will have Dr. Mazhar's opinion after this, like, about that. So the left parietal was a very simple, straightforward, linear incision, right? And for the frontal that I would have planned would be a flap, to raise the flap, and and doing a little bit. So that was my thought process. And when I'm not going to remove the all the tumor, and I want to confirm I want to have the tissue biopsy and debulk and reduce the pressure, so that's why I opted for the parietal lesion. Fatma, you were saying something?
I just wanted to ask one thing, that the lesion is multiple, and edema is completely involving the majority of the left side. And do you think that the outcome would be better if we try to resect everything? Because I think we cannot do just more than debulking. सो अगर दोनों रीजन्स को हम निकालते भी और दोनों तरफ जाके भी क्रॉस टोटल करने की
Yeah.
कोशिश करते हैं, तो आई डोंट सी अ पॉइंट giving benefit to the patient since it looks like a high grade lesion. Second thing is, in frontal lesion, I think it's already involving the corpus callosum, so we need to we cannot do more in that area as well.
Right. So yeah, those are also valid points. So, I mean, but like I said, like there are some cases that I saw where they used two different incisions. They didn't, they, and then they removed the tumors or they did the debulking. The mindset was that, the more abnormal cells you remove, the better chance you are giving for the chemo radiation. But, Dr. Riaz and Dr. Altaf, I can ask you this question. Have you seen, if you go with such lesions and you try to be more aggressive, like the frontal are is getting kind of butterfly, not really, but like not the typical butterfly lesion. Have you seen a brain getting angry and after, the kind of a debulking, uh, the pressure getting increased or something like that?
Are you asking both, or you are from
I
all?
can start with you. I can start with you, then I'll ask Dr. Altaf. Because
Okay,
yeah,
I did one surgery, and I will show you next time. We will send
okay,
you the all the pre and post op pics.
perfect, perfect.
And in front, you can also have a chance of the lobectomy. So
Hmm.
it is if the it never. But I was that tumor was just frontal, and that was from the right side. My opinion was the right-sided frontal lobectomy, but
Right,
I didn't do the lobectomy. I just went into by making a window. I went and maximum tumor I have removed from the right side, and also that was present up to the corpus callosum. I think patient is fine, and he didn't have any problem post-op. And
okay,
but again, there are two possibilities that one is the vessels, which are deeper when you are going to remove the tumor, and the
yeah,
surgeon is such type of the person who is enjoying removing the tumor, so he never think about the vessels. So the vessels should be keep in mind. Second, opening of the frontal horn of the ventricle is again a problem. If the little blood goes into the ventricles, the patient's post-op outcome will not be as good as we are thinking. So these two things should be keep in mind, and you can easily remove the maximum tumor because you know that this is a highly malignant tumor, and if it
right,
isn't going into the corpus callosum, you don't want it to remove whole of the tumor.
right, right. Agree. Dr. Altaf, want to add something?
I first endorse Dr. Riaz Raja's standpoint that we have to be careful about vessels. And one of the glamour surgeon who we do I had a meeting with him and kind of discussion. He used to say that I don't use bipolar at all in glamour surgeries. And that is a kind of principle because bipolar gives the deficit, not the tumor resection. Be in the question which you asked is about the bleeding, post-op bleeding and swelling. So it's called wounded glamour syndrome, which causes kind of swelling after surgery or bleeding after surgery. And wounded glamour syndrome happens when there is a significant residual tumor. If you are able to resect significant portion of the tumor, and that happens especially in the tumor where there is a edema and the infiltration. So if the lesion is circumscribed, then you can opt for a lobectomy. Having said that, this is the left side, and left side carries the risk of aphasia. So if you do the
Right,
lobectomy, right side is a bit kind of forgiving. You can do lobectomy with
mhm,
impunity.
right, right. I
In
agree.
in
True.
in this in this particular case, yes, you can opt for giving two incision, resecting the posterior one and the anterior one remaining within the tumor capsule because left side again dominant side giving deficit is a kind of painful thing, and neurosurgery dictum is simple: you have to avoid giving deficit as a surgeon. Disease, if disease process is giving any deficit or any morbidity, then it's a natural process, but as a surgeon you have to prevent morbidity at all costs. Yeah, so this is my take on this.
Right, right. So we do have other surgeons here. I can see in the meeting. If anybody wants to add their opinion, please feel free to raise hand or can unmute them. And meanwhile, I can go to Dr. Mazhar. Dr. Mazhar, the bihistopath came out to be like so high grade glioma with features favoring astrocytoma WHO grade 4. And yeah.
Yeah, definitely now it's a high-grade tumor and grade 4, and you have done debulking. So patient would need radiation, and I would give temozolomide along concurrent with radiation, and then after completion of radiation would continue chemotherapy for 6 cycles of temozolomide.
Okay. And so in these tumors, do you see any significance of molecular markers like 1p19q codeletion or something like that? Or do we go for that? Or, it's like the features are showing that and the tumor is aggressive, behaving aggressively, and we do have histopath also. What will be your recommendation as an oncologist in this?
You're asking me?
Yes, sir. Yes, sir. There
Yeah,
should be a
I
molecular
I
marker.
think like इस GFAP positive है और इसका Trex retain chi-score 67 is 30, P53 wild type और आप लोगों को high grade glioma है, तो I think if the facility is available, one can go for further markers, but that would be enough for our further adjuvant treatment after surgery.
Right.
Grade 4 would be behaving like or GBM, like it's almost same, and the treatment and radiation doses and chemotherapy is almost the same for this. So it will not change our actually treatment plan.
Yep. Thank you. Okay. So any questions from our attendees, panelists?
But
We had
one thing that I would like to add.
Yes, sir.
There are two sensitive areas regarding the dose of radiation. One is the optic chiasma and the other is brainstem. So both these areas do not tolerate doses higher than 54 gray. So when we draw the volumes, in this case, we would mark optic chiasma and we would mark the brainstem, and we will see if, because the dose that I would recommend here would be 60 gray. But again, if the organ at risk are coming in our field, or if our doses is hitting those areas, then I would reduce the dose and depend more on 54 gray, along with very aggressive continuity of chemotherapy for even more than 6 cycles. But again, it depends. Once we mark the tumor, our CTV, PTV, and our optic chiasma and brainstem. So if the doses there is less than 54 gray, if I'm giving 60 gray to CTV, then I would give 60 gray. If optic chiasma and brainstem field में आ रहे हैं हमारे, तो फिर I would reduce the dose to 54 gray.
Okay, that's really good information, and I really like the discussions in the tumor boards. So we have Dr. Iqbal also, who is a neurosurgeon. I think Dr. Mehboob is also our neurosurgeon. So sorry, a few of you I do not know in person, but anybody can ask questions. And Dr. Madar, we had a very interesting discussion last weekend. We had this symposium where one of the speakers said, very rarely though, like less than 5%. No, this is not the perfect case for that discussion, because this looks like, the high-grade glioma.
Yeah.
Like sometimes the molecular markers, we don't go for that in LMICs because of the money issues. We don't have resources, or we don't have the facility, and then we don't have the money. Sometimes the diagnosis cost, the many days in the ICU and the miserable outcome. And then when we get the molecular things done, and then the diagnosis gets changed, and then, the whole treatment gets changed. But the percentage is less than even 10%, or maybe less than 5%. But he was having this opinion that, we need to find a way how we can, think about those patients where really the molecular markers are important, so that, we don't misdiagnose those patients. So
yeah, I think it's fine, but again, as you said, it depends on your institution, upon the financial status of the patient and the availability of these markers. So, and then if there is a controversy in pathology and radiology, then one can go for further marker. But if radiologically, if it's a high-grade tumor and the basic test that normally that you have done points out to, so it would not add much to it, but in cases of controversy, one can go for markers.
Yeah.
I mean, then that becomes an important issue.
Right, agree. Okay, so if no further questions or any points, I think that was our last case. And I thank you all for joining us today.
Thank
Thank
you
you,
very much. Very
Dr.
interesting. Yeah.
Well, really, it was wonderful. I really love our discussions in the tumor board. Thank you, Dr. Riaz. Thank you, Dr.
Thank you,
Altaf.
son. Thank you.
Dr.
Thank you so
Shumaila.
much.
Thank you,
Thank
Dr.
you.
Shayan.
Thank
Thank
you
you
so
so much for joining us. Thank you all.
Thank
See you
you.
next
Allah
week,
Hafiz.
inshallah. Allah Hafiz.